I open this academic ceremony in which Mr. Leao will defend the academic thesis Unlocking Value in Healthcare, Barriers and Success Factors in the Introduction of Value-Based Payment Models in Dutch Healthcare System. I welcome you and wish you lots of luck. I welcome also your paronyms, of course, and your supervisors, Professor Groot, Professor Pavlova, Dr. von Vechel, and of course the members of the opposition, whom you will meet later during the opposition, and of course your guests on site and online. But before we start the opposition, we give you the opportunity to explain to your family and friends what you have done in your thesis.
Thank you very much. Dear Prorector, dear members of the Defense Committee, dear friends, families, colleagues, supervisors, in the upcoming 15 minutes, I will present the main results and the main conclusions of my doctoral dissertation titled Unlocking Value in Healthcare, the Barriers and Success Factors in the Introduction of Value-Based Payment Models in the Dutch Healthcare System. Nowadays, the population is getting increasingly older, and with that, chronic illnesses arise at a larger rate. We also have an overall scarcity of healthcare professionals, and it becomes visible the need for efficiency in healthcare. However, there's a high level of waste, with care being delivered at higher costs and not necessarily at higher quality. To manage expenses while enhancing value for the patients, value-based healthcare needs to be implemented. One of the main elements of value-based healthcare is the payment component. Globally, the prevailing approach entails that providers receive predetermined payments for each individual care service that they provide, irrespective of the patient outcomes. This can lead to overtreatment and impedes interdisciplinary collaboration. Therefore, there's a need to shift from paying for services to paying for value. And this is called value-based payment models. Value-based payment models are, of course, not without unintended consequences, such as providers seeking easier to treat patients in order to enhance their financial gains. And this underscores the need for a careful design, implementation, and application of value-based payment models. In the Netherlands, specifically, there's an overall lack of a broader scale implementation of value-based payment models. Now, taking all of this into account, this dissertation in a first part aims to explore the barriers and the success factors of value-based payment models. Here, we have 2 systematic reviews and 1 Delphi study. Then, in a second part, we aim to apply these insights to the Netherlands Heart Network, which is a regional collaboration that involves 4 hospitals and 2 GP care groups, as well as apply the insights to the Netherlands Heart Registration, which is a national registry that focuses on both collecting and analyzing cardiovascular-related data. Here we have Chapter 5, a mixed method study, Chapter 6, a cross-sectional study, and Chapter 7, a descriptive and explorative study. Starting with Chapter 2, we aim to identify the facilitating and inhibiting factors in the design, implementation, and application of value-based payment models. There were 143 publications in total included, and insights suggest that since implementing value-based payment models requires a lot of change, it also takes a lot of time for improvements to manifest. And besides that, staff workload may also increase. This may cause a loss of engagement and trust in these models. Focusing on realistic and achievable targets keeps healthcare providers more engaged, and it drives real improvements in care quality and cost efficiency. This overall contributes to the success of value-based payment models, and additionally, a high level of transparency and communication also will keep the team more coordinated, allowing them to perform their tasks more effectively. In this chapter, consensus appears to be a common element. There needs to be consensus among the stakeholders on the primary objectives of value-based payment models, as well as consensus on the strategies to achieve those set objectives. Healthcare staff needs to be kept motivated, well-informed, and actively involved. An additional systematic review aimed at exploring the impact that different types of value-based payment models have, as well as explore what facilitating and what inhibiting factors are associated with each type of model. The same search and selection process was used as in Chapter 2, but with the addition of including publications that mentioned clinical, cost, patient-related, and organizational-related outcome measures. Insights found an overall positive effect on clinical and cost outcomes, and this should demonstrate the overall success of value-based payment models. However, most organizational-related outcomes are negative. Providers seem to lack awareness, trust, engagement with the models, which may be justified by their exclusion from the design of said models. This decreases their sense of ownership and therefore their motivation. It is therefore concluded also that targets and incentives, if they are adequately designed, they promote the model's success. However, these factors require care coordination among the stakeholders that are involved, namely transparency, communication, and trust. Additionally, since value-based payment models, as I've already mentioned, they require a lot of changes, and these changes can be procedural, behavioral, or even structural changes, that increases the complexity, and together with the lack of experience that some stakeholders may have, may become prominent inhibitors for the success of value-based payment models. Now, after the first systematic review, the one in Chapter 2, there were several inhibitors and facilitators that were found, but we also wanted to explore the importance of those factors. Therefore, a Delphi study was conducted in which 15 experts were asked to rate the importance of factors on a 5-point Likert scale. The most important factor was the timely availability of data and the integrated IT system for data registration. Such an IT platform, it allows for quick information, quick access to this information about patients by all the healthcare providers, where they can more easily exchange data with each other. Measurable factors also appear to be important, having adequate outcome measures, targets, benchmarks, incentives. All of those are important for the success of value-based payment models. However, the harder to measure, more intangible factors also play a very important role. A strong leadership and a constant flow of information to ensure transparency and engagement among the involved stakeholders, they seem to be key elements that experts consider important for the success of value-based payment models. Now that we explored and we analyzed all the factors that shape value-based payment models, we decided to move our attention to the applications of these insights to the Netherlands. In Chapter 5, we introduce a method to monitor the impact of value-based payment models and present also the results of the first implementation of this monitoring method. Now, this method consisted of online questionnaires, semi-structured interviews, and case mix analysis. And the intent was to monitor the intended effects, so the attention to the patient outcomes, as well as unintended effects, the risk-averse behavior. The implementation of this monitoring method in a Dutch outcome-based payment model, it proved to be successful. This payment model led to more attention to clinical outcomes. It didn't lead to any risk selection, and according to this monitoring method, it was also said that it did not lead to concerns of public reporting of treatment policies for higher risk patients. This method overall proves to be very valuable, and it can be used in almost every healthcare system, since both the aim and the risks that are associated with the introduction of value-based payment models are not necessarily specific. In Chapter 6, we investigated the experiences that stakeholders that are involved with the Netherlands Heart Network have, as well as provide insights into the importance of factors that either facilitate or inhibit the network. Here, an online questionnaire was conducted in which the stakeholders, which were the participants, were asked to rate the importance of 16 factors, again on a 5-point Likert scale. The most important factors, according to the stakeholders, were adequate collaboration between the general practitioners and the hospitals, an active involvement of medical specialists and/or physicians, and transparency, communication, and trust between the stakeholders. These factors that I just mentioned, they appear in both more complex infrastructures, such as the ones that were analyzed in prior chapters, as they also appear in simpler ones, such as the Netherlands Heart Network, which lacks a payment model component. Finally, the last study of this dissertation, we decided to take a step back and we analyzed the current stakeholders' perceptions about value-based healthcare, as well as identify the barriers to its attention and propose strategies to increase the inclusion of value-based healthcare in contractual negotiations between insurers and hospitals in the Netherlands. There was a standardized questionnaire that was used on hospital executives, health insurer executives, and value-based healthcare experts. After this study, it becomes increasingly clear that implementing value-based healthcare in contracting is quite complex. The predominant focus on financial gains, the organizational resistance to change, deficiencies in the data infrastructure, they all present a complex set of obstacles to allow for the potential benefits of value-based healthcare. However, policymakers, insurers, healthcare providers, they can all work together in order to help with the adoption of value-based healthcare in contracts by prioritizing long-term contracts that incentivize value as opposed to the amount of services that are provided, by prioritizing trust and transparency between insurers and healthcare providers, and by investing in advanced IT solutions that allow for both data collection and data exchange. Now, the contributions that this dissertation may give can be divided in both practical contributions and contributions to research. Starting with the more practical contributions, this research highlights a core layer of value-based healthcare, and that is mutual trust between insurers and providers. By building trust through shared performance metrics and an upgraded IT integration, it ensures that long-term contracts, they consistently drive better patient outcomes and also a more efficient use of resources. Our findings also show that engaging several stakeholders in defining the goals, it helps them ensure that those targets, those goals, they are balanced, and they're also considered to be shared milestones that everyone understands and everyone supports. This research also points to the need for standardized metrics and an improved IT infrastructure. When all stakeholders agree on clear definitions, such as, for instance, how to capture patient-reported outcomes, the data will flow more smoothly, more rapidly across the systems, which will make cross-organizational comparisons more meaningful. Finally, this research introduces a simple, easy-to-use monitoring method, and when using it, the administrators can spot problems early and they can adjust rapidly. As for contributions in research, it is shown that value-based payment models, they contribute to an improvement in care quality. This should serve as a major argument on the importance of implementing value-based payment models. The research also points out that the success of these models is driven by key facilitating and key inhibiting factors. We found that a clarity in the performance metrics, leadership, engagement, IT readiness, they all facilitate the adoption of these models. In turn, misaligned incentives and a lack of interdisciplinary engagement can inhibit the progress. The importance of collaborative network structures in value-based healthcare delivery is also shown in our insights. When integrated care and networks of care are put together and they work together with good synergy, care coordination improves and duplication decreases. Finally, this research also highlights the influence that financial incentives have on outcome measure prioritization. So, for instance, if there's an increasing of incentives for specific outcomes, then the healthcare providers will feel encouraged, incentivized to prioritize those outcome measures into their everyday clinical flows. However, as unintended consequences seem also to be a reality when it comes to value-based payment models, these incentives need to be well balanced so as to avoid an over-focus on those specific measures. Overall, all these insights that I showed you, as well as many others that this dissertation can give, they aim to ensure that every stakeholder, from patients to policymakers, can contribute to and benefit from a more value-driven healthcare system. I thank you very much for your attention, and I pass the word back to the Prorector.
Thank you very much, dear candidate, for an interesting lecture and presentation. And now we come to the opposition, and the first opponent is also the chair of your assessment committee. That's Professor van Meerode. He's professor in logistics and operational management in healthcare in the Maastricht University Medical Center. Professor van Meerode.
Thank you. Mr. Candidate, dear candidate, I want to compliment you with your thesis. I also want to involve your supervising team in my compliments. But now for the questions. I was a little bit amazed about one proposition. Value in healthcare means different things to different people. So I want to know from you a very concise answer. Mm-hmm. What do you consider as value, and on what theoretical reasoning?
Highly esteemed opponent, thank you very much for the compliments and for the question.
Yeah.
For me, value, I used the definition that Porter uses as well, which is outcomes divided by costs. I do believe that, taking into account the proposition that value means different things for different people, that this is not the same definition that everyone uses. And that can be a more or less prioritization that people give, may that be any types of stakeholders give to either the patient outcomes or the costs. There are a lot of stakeholders that give a lot of importance to the costs and to the idea of cutting costs even if the patient outcomes are not achieved or if quality remains the same. But I do believe after all this dissertation that patient outcomes, patient quality should be prioritized here without, of course, taking anything away from the costs.
Yeah, one of the questions following that is, what is new about Porter? Because in many countries like the Netherlands, UK, United States, they have some 30 years tradition of health technology assessment, meaning that, for example, an outcome could be from such an assessment that you don't allow certain techniques to be reimbursed because it has no sense to apply that to people above 90, an arbitrary example. How does that approach differ from your point of value you have chosen?
In my opinion, value-based healthcare it can be applied to most of what is the healthcare system, but not everything. So in my eyes, what is done not just in the Netherlands, but in a lot of countries in this world, is much based on fee-for-service models, which has to do with the amount of care services that are provided, and not necessarily on value, on patient outcomes. And for me, what Porter adds that is not maybe being done here, which I believe your question moves me towards, is two, I guess, of the pillars, according to Porter and Lee, that they published in the Value Agenda, which is the integrated care, as well as the integrated practice units, of course, as well as these geographic expansion and integrated care across several facilities.
To make it more specific, we know, for example, that dialysis for people of a certain age has more negative consequences, no qualities, positive qualities compared to no dialysis. In many examples of value-based healthcare, I see that there is a discussion. Does a patient want that dialysis or so on, where we know that has no sense? Would you plea that such interventions are taken outside the value-based healthcare model and that they are not allowed on the market?
I do plea, indeed, that there are several conditions that don't necessarily benefit from value-based healthcare. When it comes to the dialysis, I am not an expert in it. I would have to see the cycle of the patient when it comes to the diagnosis to the treatment. But to answer your question, I do believe that there are several conditions that would not necessarily benefit from value-based healthcare. For instance, diabetes, that would benefit a lot because it has a long care cycle for the patient, which, for instance, establishing bundled payments, it would be quite beneficial, not just for the patients, but for the hospitals and the health insurers as well.
when you say the value difference can be different between people, don't you mean the value is different between different contexts? I remember from my secondary school when I had my first economy classes that I was asked, what has more value, a diamond or 5 liters of water?
Mm-hmm. And it depends on the context.
It depends on the context.
Yes.
Yeah. So is it not much more important to stress the context instead of different people?
I do believe that by different people, I can only assume that you mean also different conditions that they have. Yeah. I do believe that the context, indeed, it very much influences value-based healthcare and whether or not it should be applied. Yeah. But I don't think it necessarily should be only about the context. I agree with you wholeheartedly that, for instance, if there are specific regulations that make it very hard for value-based healthcare to be implemented, such as, for instance, the way that physicians are paid, for instance, that it's hard for value-based healthcare to be a core in the certain hospital, in the healthcare system, for instance, in the Netherlands. Yeah. So context is very important. But it also, from several articles that I've helped write, it also makes me think that the conditions also cannot be taken away from consideration. Not necessarily applying value-based healthcare or value-based payment models, if you want to be more specific, to all the conditions, but starting with one condition that is known to be at least some proof of concept there, for instance, diabetes, with diabetes existing here in the Netherlands so successfully, and starting from there, get proof of concept, and then decide to expand on that. But I completely agree that there needs to be research about the differences that exist between systems. If the system is more top-down, bottom-up, where the decisions come from, if there are certain regulations that are needed or not, that, of course, makes a lot of sense and will really influence a lot on the application of value-based payment
because now we are where we have to be. Suppose I'm a doctor, and I have to discuss with a certain patient what would be the best option, and it depends on the person, not on more on the person on the context, right?
Yeah.
And I know that my hospital has a contract, and the insurer translates value also with costs. Isn't it so that as a doctor I come in a very arbitrary position, because the financial risks are decentralized into me, in fact? How do you see this?
In my opinion, the shared decision-making, of course, it's a core element of value-based healthcare, as you mentioned, so discussing with a patient the treatment that we're talking about. However, there's also other shared decision-making, as you very well point out. It may be very hard to apply because if every patient is different, every patient will want maybe different treatments. I do also know from previous chapters as well there that standardizing, may that be transparency with treatments or standardization of treatments, is also quite important. With ICHOM, for example, the organization being so adept into standardizing these outcome measures. And the treatments themselves, in my eyes, also need to be standardized. So when discussing with the patient the possibility of treatments, there needs to be a discussion not as open as what would you like to do, but mainly giving them the options that they have and then the consequences of them, not necessarily having a conversation as open as maybe it may sound like.
Okay, so you distinguish three things: the well-informedness. The second thing is people have freedom to choose. As a patient, disregarding the risk for the doctor. And the third element you mentioned, also Porter mentioned this, but this is not unique for Porter, that is that healthcare organizations should be much better, standardization, so on. So it is a bit tricky to put the last element in discussion of freedom for choosing.
I completely agree. Freedom is quite relative, I would put it like that, because if you give patients, for instance, all the freedom that they can have, then I'm assuming value-based healthcare will not be as optimal as one can see.
So maybe if you say this, value is not so different from people.
Value is not so different from people. I completely agree with that. Yeah. And the differences and the balance that you need to establish don't just stop on shared decision-making. Yeah. They also can go to the amount of incentives that you give hospitals. They can also go to the amount of freedom that you even give for the contractual negotiations. Everything requires a balance there. With the incentives is the best way for me to tell you that, and everyone, that if you incentivize too much a certain outcome measure, then everyone will want to have the best outcome measure there, so they get paid more, and other outcomes will be maybe forgotten. So there needs to be a balance there as well, just like it exists for shared decision making.
A last question. I consider this as an enormous game that's going on, and the biggest risk taker at this moment is maybe the bank, because they have to give the loans, and they are looking at this game. How would you consider the willingness of banks to manage their interest rates?
That's a good question. Would you mind rephrasing that so I can fully understand what you're asking?
Yeah, somebody should pay the building and so on, and the most healthcare organizations are completely dependent from loans from the banks, and they will make a risk profile of the healthcare organization. And now we have mainly short-term contracts with an arbitrariness of the margin hospitals get, and if the hospital should go bankrupt, then the bank has its loss. So banks are looking at this game, what's going on. So
that's a very interesting way of going about that. It's true that all these changes would also influence banks, for instance. So changing even the way that it's paid would also change that. In my eyes, this is something that needs to be open the conversation to also the funders themselves, assuming that the hospitals, in this case, as banks do fund, and there needs to be investments also when implementing, for instance, value-based payment models or value-based healthcare as a whole. The banks need to come into question to maybe refinance or rethink the terms of the agreements that they do have when it comes to maybe in the first few years that this is applicable. As I mentioned in chapter 2 and 3, it takes time for improvements to take effect. And because of that, also banks need to be aware that in the beginning, you will not see right away the good things that can come from value-based healthcare. It always has to do with the long-term thinking. May that be of insurers, hospitals, and banks.
I want to stop you. Thank you very much. I think you would also have success as a political career.
Thank you.
Thank you, Professor van Meerode, for your opposition. Now we come to the following opponent, who's also a member of the assessment committee. That's Professor Evers, and she's Professor of Public Health Technology Assessment and also Director of the Capri Institute in the Department of Health Services in the University of Maastricht. Professor Evers.
Thank you, Pro-Rector. Dear candidates, with great interest I've read your thesis. It's very close to my own field, health technology assessments, a very important topic, and you really performed well and also had some nice commentaries I saw in your discussion, so I like it. I would congratulate you on your work and also would like to include your supervisory team and your beloved ones, either here or online. I would like to continue a bit the discussion where Professor van Meerode left, and that's basically the basis of your model. And I would like to ask one of the parnyms to read aloud Proposition 1. They're not numbered, but the first one.
The first one, right?
Yeah, the first one, yeah.
Not all elements of value-based healthcare have been applied to the same extent as proposed in the Porter and Lees model.
And you already explained in your discussion, because it's organized around your propositions. But what I wondered a bit is, there is a proposition behind the proposition is that all elements of Porter's have to be there. And I am wondering a bit about that. And is there any evidence that it has to be there? So maybe you could, to start the discussion, elaborate on that. Yeah.
Highly esteemed opponents, thank you very much for the very nice comments and for the question. This first proposition that not all elements need to be present, it mainly comes from Chapter 6, that if everyone remembers, it's the NHN, there was a study made on the NHN which does not have a payment model component. And even though the conclusions of that study mention that the same factors affect both more complex and less complex networks, in this case the Netherlands Heart Network, it didn't necessarily conclude, and there's no evidence that they perform exactly the same as with all the components there, so with all the 6 pillars of Porter there. However, there has been, there's evidence in the Netherlands with the payment component that indeed applying it without the payment model, it also reached good outcomes such as lower expenditures and higher patient outcomes. And this proves that even though there wasn't a comparison between the same organization with and without a payment model, so we cannot know for sure that they have exactly the same results. We do know that they also function without some of the pillars there. And then besides that, as it's mentioned in the discussion, there are certain elements of Porter, may that be integrated care, networks of care, measuring costs and outcomes, that are implemented in certain organizations and networks which have very good results and not necessarily with, in this case, the bundled payments, the payment model components. And this shows that not all the elements need to be applied.
But this also shows that probably some other elements might be relevant.
Exactly.
Yeah. Hey, and if I look at your thesis, then you looked, for instance, mostly in the Netherlands, besides the literature, and you also looked mostly at heart diseases. Could you say which part is transferable to other diseases and to other countries without any adaptations? And if you look at the limited generalizability, where would there be a struggle? So what if I would like to implement this, for instance, let's say in depression in Portugal, what would be the things where I have to be aware of? Looking at the results of your thesis.
Of course. Coming back to what Professor Van Moro was saying, the context is always important to see, so I wouldn't necessarily apply it. I wouldn't necessarily say that.
What do you mean by context then?
Context, exactly. So the context may that be the type of healthcare system, if it's multi-payer, single-payer, whether, for example, in the United States, we're talking about more top-down structures, that the top part, if you will, of the hospitals, for instance, take much more influence on whoever works there than, for example, in the Netherlands, where it's proven that in the Netherlands, for instance, that physicians, healthcare providers have much more influence on what's going on in the hospitals. I wouldn't say, therefore, that it's a one-size-fits-all. However, there are many conclusions that are taken here that can be applied because they're not necessarily context-specific. So what I mean by this is conclusions such as that a transparency that needs to happen between insurers and healthcare providers needs to be there. Of course, if the government is more involved on a certain healthcare system that has, for example, single payer, then the government also needs to be involved in these discussions. Collaboration, trust, leadership, communication, collaboration, integrated care, all these more intangible factors need to be present always, and I believe they are transversal to the context, to the healthcare system, to the regulations.
Sorry to interrupt you, but are you then saying we need a system which is top-down, uniform, transparent, government-oriented, and then we can do this? Because then I'm afraid that there are not too many systems in this whole country setting which are left to implement value-based healthcare. It sounds a bit crude to me if looking at your work and the implementation. Yeah.
It's more, this study was conducted in that context, but it can be applied to other contexts as well. Of course, there needs to be tests whether or not the factors that do influence this influence on the same type of extent. So in my eyes, the factors are the same, especially the more intangible ones, but the extent to which those factors influence, that can be studied from system to system.
And you cannot give a top 5 of if I would do this in, let's say, Portugal and depression, these are the top 5 factors which I would consider then.
I can say that. I can say for sure that the number one factor would be a functioning IT infrastructure. And that has many factors in between it, because not just the platform needs to be well integrated within the hospitals and the insurers, but this also means more transparency when it comes to data between insurers and the hospitals, which, for example, is something that the last chapter of my dissertation found, that there's simply no transparency there. So an integrated IT system, I think, would be the most important factor to be implemented there, and can be transversal to any sort of healthcare system in my eyes. You need to be able to share, to exchange the data. That data will help the patients, but also will help implementing value-based healthcare in the future in other conditions as well. So that would be number one. And then number two...
Can you be briefly about the other ones?
Of course. Then number 2, 3, and 4...
I have a zillion other questions if I have time left, but I don't think so. Yeah.
But really rapidly, I would just say that leadership, communication, collaboration, cooperation, and if I must add one more, the incentives. The financial incentives, I know it's very hard to say exactly which type of incentives, but that they need to be balanced. And that needs to be studied, of course, from healthcare system to system, but they need to be balanced to incentivize.
Yeah. If I can have one short question. I'm looking
A short question and a very short answer.
Yeah. One of the things, if I look at the evidence which is behind your thesis, short question, is that it's consensus-based. And that's also, if you look at the earlier chapters, you look at consensus in the Delphi. I'm wondering a bit, and maybe a short answer, the selection of your experts is very crucial, and I couldn't find how you selected those experts. Whom they are is clear, but maybe they're all believers of this system, and that's why it's what comes out of that. So that's where I'm a bit was wondering. If you can give a short answer to that.
Very short answer. The experts were contacted based on contacts that the team had, and then snowballing. But after we saw the experts and we saw the characteristics, the countries, in my opinion, it doesn't really matter, because they were value-based. They were.
Yeah, but I'm wondering a bit about, if you're pro this system or against this system, whether that's not something
that was not measured, whether they're pro or against value-based healthcare. We simply measured based on their knowledge of everything. So even though they were probably from the UK or the US or the Netherlands, they had knowledge from all over the world.
Thank you for the answers for now. I give the word back to the program.
Thank you very much, Professor Evers, for your opposition. Then we come to the following opponent, who's online and also a member of the assessment committee. That's Professor van den Heuvel, and he's professor in healthcare management at the University of Amsterdam. And I would like to thank you very much for coming all the way, albeit online. The University of Maastricht is always very glad to have guests from outside.
Thank you very much. Dear candidate, I would like to add my compliments also for your impressive work. Compliments to you and your relatives, and also to your supervisors, because this is a highly relevant subject, unlocking value of healthcare. If you succeed, it could be the key to solving all the present-day problems in healthcare. So it's very important, as I stated. My first question consists of 2 parts. It's partially overlapping with the discussion we just had, and that's the model of the value agenda of Porter. I'm just curious. I do not agree with Porter on a lot of things, and one of them is the value agenda. But if you could choose one thing to pick out of that agenda, on page 22 of your thesis, it's standing 1 or 2. Which 1 or 2 would that be?
Highly esteemed opponent, thank you very much for the very kind words and for the question. Regarding the value agenda, I do believe that even though they're not 1 or 2 or 3, the first one that they mentioned there, so that would be the integrated practice units, that together with, if I may have 3, the geographical expansion as well as the integrated care there. So those 3, because in my opinion, they all 3 speak about the same thing, which has to do with integrated care. It has to do with collaboration, with communication, not just in between the staff of the hospital, but also in between hospitals and insurers, for instance, and even with the payers. So that would be what...
Thank you very much. Thank you very much. Thank you very much. We do not agree, but that's the whole issue of this meeting, of course. I think the one thing you should do is to measure. And that's point 2 in this scheme. And because we do not measure enough, we do not know the situation, and we do not know what we have to do. And the integrated, and especially the bundled care, I have an answer from ChatGPT. If the time's there, I will give you the answer. But it makes the whole case much more complicated. Having said this, measuring is important, and the next important thing is paying for value. Because if you want value, you have to pay for it. And if that goes wrong, you get the wrong incentives, things go the wrong way. So looking at the scheme of the healthcare payment learning and action network, I find it a bit confusing. Fee for service has brought us where we are now, paying for the wrong things. Fee for service based on quality and value, okay. Risk sharing is not a payment model, but more something you do after a payment model. And you have the population-based models, for example, a global budget. I wonder if we hypothetically give a hospital a budget, a global budget, I think that would be the best option possible at this moment. But you have studied all the payment models. Which improvements could you find or imagine above the global budget that would improve the payment system? So what would make the global budget system better with your proposed improvements?
Yeah, thank you for the question.
What would you suggest?
I would suggest, just to make it clear, that in this dissertation, the global budget, as you mentioned, that the population-based payments were not included because we decided to include only payment models where both the payers and the providers share the risk. And according to several images, several tables and research, it makes it seem that with the global payments, as you put it, the providers have all the risk because you just give them a payment, and the payers give a payment, and that's it. So we did not include that. I do agree with you that a global payment would be, so the capitation, if you will, also it's among that category. But global payments, even though they're different, it would be ideal, in my opinion, as well. But I don't think, if I may be frank, that it would be, in the moment that we are right now, feasible for hospitals, even here in the Netherlands. And I think it would come from how we can make it better. Because in my eyes, global payments right now don't work because providers don't want that much risk. And they don't want that much risk. They feel like they're being too much observed. It's too much pressure for them to perform, if you will, and they don't want that. So in my eyes, there should be a global payment, but that should be combined with some sort of financial incentives from, for example, pay for performance, or having a minimum set procedures or services benchmark there. So just paying for the population, I think it's too much for the providers to handle right now, because the system right now is not prepared for that. And that comes to my second part, which is to improve this, and assuming that everything is allowing for the population payment to actually take effect, then the hospital itself and the system itself needs to be towards that. Because right now, the way that providers are being paid, the way that the government, the regulations exist, all of that is more towards fee for service. So if you tell a provider, here you have a certain amount of money for the population, so the population payments, maybe because they still get paid per service, they will not abide to that as well. So there needs to be an overall cultural change, and there needs to be an overall system change for that to take effect.
Yeah, it's interesting discussion. I have other experiences. I've worked with a global budget 350 million euros. And what you can do is amazing, really amazing. But that's only one example. You did research, so I have to comply to your findings. But okay, an interesting part of your study was the Dutch heart, the Netherlands Heart Network. But I wasn't quite sure what your point, the point you wanted to make. And I wondered, is perhaps your idea that paying for the structure could be an alternative way of paying of value-based payment?
I do not.
In the Dutch. Go ahead. Sorry.
In my eyes, they are not mutually exclusive. So for me, they do not mean the same. The paying for the structure or paying for or the pay for value, if you will. Paying for the structure, which is kind of what the Netherlands Heart Network is doing right now, as I've explained in chapter 6, I believe. The payment that the insurers gave to the network, that was for the collaboration, the structure, everything to allow for value-based healthcare factors, but they did not have a payment component. That would be ideal, and I do believe that the Netherlands Heart Network wants to add that component, the payment component there, once there's proof of concept that all the other factors do contribute to better value for the patient, so better quality at same or lower costs. So to respond to your question, I don't think that it's either one or the other. They can be combined, if you will.
But how do you explain they have good results? They show a level of cooperation that is not often seen in the Netherlands. So I thought, well, this is a success story. Why not do that in other places? Because there are no real success stories apart from my NS1 hospital with a fixed budget in other payments models. So why not start with facilitating the organizations to work together and just wait till they start delivering value?
I do believe that the whole organization is quite skeptic about the implementing everything that exists with value-based healthcare, including the payment models. So in my eyes, this is just my opinion from what I've seen, of course, and from the research. Doing too much at the same time might result in might have worse results than doing it gradually. And gradually can be just like the Netherlands Heart Network did. So they started with a few pillars of the value agenda, if you will, and then they want to add the payment part, so the value-based payment models, just like we're only talking about cardiovascular conditions. Maybe if there's proof of concept with what they have right now, they can go to also implementing a payment component, and then maybe other organizations or the same one will do the same for diabetes, for example, or other conditions, and there will be kind of a gradual expansion of value-based healthcare.
Okay. We have a long way to go. I told you, I asked ChatGPT. I'm not a big fan of the bundled payments in the bundled care. So I asked ChatGPT, and he has access to much more than your 5,000, very impressive, by the way, 5,000 articles you studied. And I asked, isn't bundled payment for bundled care not a bit complicated? For instance, you have to measure quality and you have to measure performance. So isn't it just a nice theoretical model? The answer of ChatGPT is, you've just hit the core criticism on business on bundled payments. Strong and logical in theory, but complex and limited in implementations. So that is also what I see, also not scientifically researched, but it's hardly not implementable in Dutch healthcare. Working together with organizations, you get discussions about how do you divide the money, who gets the payment, and who does have to do the work. So I'm very skeptical about that element, and I stick to the point that you have to measure quality. And am I still? Can you still hear me? Because oh yay.
You can finish, and then we go to the following opponent.
Yeah, I have no more I don't see you anymore, but if you hear me, then it's all okay. Can I ask one question, or am I finished?
No, we are running out of time. Thank you very much for your opposition. We come to the following opponent, and that is Dr. Peters. Her expertise is interorganizational collaboration in healthcare, and today she has also accepted the role of secretary of this committee, for which I'm very grateful. The floor is yours.
Thank you very much. Dear candidate, first and foremost, I believe congratulations are in order for you and your team on this excellent thesis. You have studied a topic that is very important, very relevant in nowadays healthcare, but also a very complex topic. So I believe congratulations are in order. I've read it with a lot of pleasure, and consequently, I also have a few questions. First, you know a little bit of my background in healthcare networks, so I'm specifically interested in chapters 4 and 6, but maybe a little bit overarching. Value-based healthcare and the definition you give is quite patient-focused. And rationally, I also believe that this is what we should do, focus healthcare around patients, but we're not very rational, humans are not very rational beings. And we know that there's a lot of different interests in healthcare. So we have the patient, the society, different types of organizations, and they're often in conflict with each other. In chapter 3, we see that there's mostly negative effects for organizations, organization-reported outcomes and experiences. And in chapter 4, you argued that it's important that organizations have high motivation and engagement for successful value-based payment models implementation. So it appears very important, but can you reflect on what strategies we can use to involve organizations more in successful implementation of value-based payment models, considering that their experiences are mostly negative?
Highly esteemed opponent, thank you very much for the kind words and the question. I do believe indeed that organizations are a crucial point here in value-based healthcare. I do point out, it's very much true, and it was a very interesting insight, the fact that there was so much negativity when it comes to the organization-related outcomes. And as I mentioned, that had a lot to do with the lack of awareness and trust and engagement that the providers, the stakeholders even, the entire team had with the model. And when reflecting that, I really only have one answer, which is their lack of sense of ownership with that. So they do believe that when value-based payment models are implemented, for instance, they, were not included in the design of those models, so it was much more top-down, if you will, also because many of the articles that were reviewed were from the US, and there, as I've mentioned, it's more top-down, the organizations, and they did not have any say in the organization itself, how the value-based payment models were implemented, as well as the outcome measures themselves. Which outcome measures are you actually trying to improve? So it's this lack of ownership that makes the stakeholders, everyone in the organization, less adept, less accepting of value-based payment models. That is one of the main points that I would say here. So logically, the solution here would be to try and involve them. Now, it's very hard to involve everyone when it comes to designing value-based payment models, but I believe that's also why there are heads of department, that's why we have even patient representatives, insurer representatives, so there needs to be some sort of equal representation. And I don't mean equal as in 50-50, more like equal as in the same percentage, if you will, in terms of importance, but everyone should be represented in the discussion when you're designing a value-based payment model. And only then will they accept.
And could you explain who is everyone?
Yes, of course. So by everyone, I mean everyone that the payments affect. So this would be the payers, which here, for example, is the insurers. This would be the healthcare providers. And by healthcare providers, we can have, of course, depending on the value-based payment model, on the condition that we're talking about, because the team on certain conditions also changes. So the team there as well as the board of the hospital, if you will. So we're talking about the administrators, the health executives, they all need to be present. So everyone has different views on value-based payment models, because it's almost for sure, some views will be surpassed and they will not think about it unless they're there. So everyone needs to be represented, from patients, even patients, in my opinion, they would need to be there. But above all, the healthcare providers, administrators, insurers, some may be part of the government as well, would be interesting to be involved as well.
Okay, thank you very much. We see also in Chapter 4 and Chapter 6 that there is, first in Chapter 4, there's no real consensus on a lot of the factors inhibiting or facilitating implementation. Do you have any ideas how that's possible?
That there's a lack of consensus on so many.
Yes, exactly.
I do believe, I did categorize them, if you will, in part of the discussion in that chapter on all the factors that were there. I do believe that first of all, methodologically speaking, how the Delphi study was made, perhaps if the definition of consensus was changed, that could have changed as well. But assuming that everything was the same in the Delphi study, and assuming the same amount of rounds were also given, I do believe that experts decided, so the participants, the experts, they decided that, for instance, there were a lot of factors regarding incentives and outcome measures, and they did not receive consensus there, in my eyes, because there are some organizations where the incentives are too little, or there's not enough financial incentives for them to consider those factors to be important. And then B, in my eyes as well, the experts found the factors that received the consensus, the ones that actually found important, they did not want to disregard them, and hence they thought these ones are the most important ones and not the other ones. So these ones were the ones that we, a research team, should focus on.
Mm-hmm. Mm-hmm. Thank you. And even more interestingly, in Chapter 4, it seems that there is no factors that reach full consensus on their unimportance. So everything becomes important. And we see a similar thing in Chapter 6, where everything seems to play an important role in a successful network. What does this mean, especially for practice, and how we should organize value-based healthcare and networks if everything seems to be important? And maybe, is this something that practice should do something about it, or is it something that we should research more or differently? What are your suggestions for this?
I would say a mix of both, starting with the quicker to answer one, which has to do with the research part, because perhaps, and I believe that was also in the limitations, of course, the way that the factors are phrased to the experts, that can change also their perception of what they think it's important or unimportant. And even though there were a lot of discussions among the team in terms of trying to have the statements more neutral, less biased, if you will, nothing can be as many people as join in on the discussion, that cannot be completely discussed and reach the point where there's no biases there. So rephrasing the factors would be, I think, an amazing way of going about that, and see if the results would be the same. But now, in terms of the more practical part of your question, I would say that if everything seems to be important, then there needs to be a way of categorizing and rating the importance of those factors, because it gets too overwhelmed. May that be for administrators, healthcare providers, insurers too, that suddenly all the factors are important. And I think that's one of the reasons that the Delphi study also comes into question. We rated the importance. These are the most important ones. We should try and apply those and then see the results, and then we can be again gradual. It's always about that proof of concept. This works or doesn't work, we take it out and we add it in. And then the other factors also can come in. As Professor Van Heuvel was also saying, the payment part is very important, and I wholeheartedly agree with that, but it's something that from these studies seems quite hard to implement, so maybe that should be a little bit later, and seeing then after if it works or not, and for which conditions and context. So healthcare systems, regulations, countries, etc.
Mm-hmm. Okay. I was reading your chapters, Chapter 4 and 6 specifically, on facilitating and inhibiting factors of value-based payment models and also of the network. And I saw a lot of overlap between those. They have a lot of the same facilitators and inhibitors. You also say that networks is one of the facilitators of value-based payment models. And in the literature I know on networks, I also see that a good payment structure is also essential for a network to become effective. So I do a lot of research on these networks, I observe them. If I go to these networks, what should I tell them they should do first?
You may very shortly answer. We can also do it after.
In a very quick part, I do believe that networks are also a facilitating factor, but as it was in the value agenda of Porter, that networks need to be implemented first. So my main point with the whole research is that networks need to be implemented as in value agenda. So they are a facilitating factor, but a core element there.
Okay, thank you very much, Dr. Peters, for your opposition. Mr. Leao, the time appointed for the defense of your thesis has passed, and the degree committee will now withdraw to discuss the quality of your thesis and the way you defended it. And I request that you and your company on site and online await the results of our deliberations and our return to this room. And with that, I suspend this ceremony.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. All your time, 'cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Hit the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. Even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. fly by now, don't waste all your time. 'Cause I'll go the extra mile.
I reopen this academic ceremony. Mr. Leao, the degree committee here present has assessed the quality of your thesis and the way you defended it. You defended it in view of its positive verdict and taken into account your previous qualifications. The degree committee has decided to grant you the degree of doctor. Professor Groot is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite, therefore, Professor Groot to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times? To be careful and honest, transparent, independent and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Diogo Luis Lopes Leao, the degree of doctor and grant you all the rights attached to it by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary and the other members of the committee and affixed with the official seal of the university.
Thank you very much. Yeah, it's done. Yeah, done. He wants to take many of them. That's okay. Thank you very much. You can put it there.
Dear Dr. Leao, dear Diogo, it's a great honor and pleasure to be the first to congratulate you with your doctorate degree. I also do this on behalf of Milena and Dennis. We all three feel very proud about what you have achieved. You have written an excellent dissertation that increases our knowledge on value-based care and the problems of implementing it on a wider scale here in the Netherlands. Your dissertation is rich on insights on the barriers and the facilitating factors that determine the implementation of value-based healthcare. It's impossible to highlight them all here. One recurrent element is the role of trust. The review of the literature in chapters 2 shows that networks of care are more effective if participants trust each other. Similarly, in chapter 3, you conclude that the lack of trust is an inhibitor of value-based payment models to work. The experts interviewed through the Delphi method in chapter 4 also mention trust as an important facilitating factor. In chapter 6, the stakeholders of the Netherlands Heart Network also mention trust as an important determinant of the success of the network. Finally, insurers and hospital executives in chapter 7 mention the lack of trust as an important reason why value-based care is not part of the contractual negotiations between health insurers and hospitals. This is an important insight that your dissertation provides, because in the value-based model of Porter and the value strategy related to it, trust is not explicitly mentioned as a key factor. Your findings here provide a valuable addition to the value-based healthcare theory. Trust, of course, is important in many areas of life. The political scientist Francis Fukuyama argues that a high degree of social trust is essential for societies to prosper. We currently witness how in the United States policies that erode trust are quickly demolishing economic growth and civil society, including universities. Anyway, trust is important everywhere. Most of all, of course, in personal relations, such as the teamwork of doing research. Our trust in you and your capabilities to write an excellent dissertation have been warranted extremely well. And your defense was even supported that as well. A major achievement is that in less than 4 years, you have been able to publish 6 excellent articles on the topic of your dissertation in good peer-reviewed journals. You also published 1 more paper based on your master thesis. This is an exceptional achievement that very few PhD candidates manage to achieve. The fact that you had to overcome the language barrier in addressing value-based healthcare issues in the Netherlands, and that you acquired many new skills in doing research, were no obstacles in that. We have come to know you as a hard-working and, above all, a fast-working researcher. Arriba, arriba, to quote Speedy Gonzalez. This seems to apply to you as well. In less than 4 years, you've built an impressive track record in publication and completed an excellent dissertation. Speed characterizes you in other areas of life as well. When it comes to speed, you remind me of one other famous Portuguese, the football player Cristiano Ronaldo. Ronaldo is known to be the fastest player ever. It is said that he can run more than 35 kilometers per hour, and in his prime time, he ran even 38 kilometers per hour, which would make him the fastest player ever. You're also the fastest, but then in talking. An average person like me can speak approximately 130 words per minute. I think you can easily double that. Like Ronaldo, you're also unstoppable. Not for the defenders on the football pitch, but for us as supervisors when it comes to talking as well. Fortunately, like us, you have to breathe every now and then, and that gave us the moment to intervene once in a while, although you were able to hold your breath for a very long time. I must admit that frequently after our weekly meetings to discuss the progress of your work, I needed a few minutes to recover from the overwhelming information, the number of words and the talking you had done. We thought it would be the ultimate challenge for you to perform interviews, asking short questions, and have to listen to the answers. But we must conclude that this is also part of your broad spectrum of talents. Not only can you talk fast and extensive, your writing is like that as well. You wrote your articles sometimes faster than we could read them. Anyway, it was a great pleasure to work with you, especially because you're a very nice, engaging and social person. You were also an actively involved member of the PhD community as PhD representative for the Research Institute. In the speed of life, you have already made plans for the future as well. You plan to marry soon, with your paranymph, I gathered, and relocate to Spain to start a new life there and continue your career closer to your family in Portugal. Finally, let me again congratulate you, Dr. Leao, with your excellent achievement, also on behalf of Milena and Dennis. I want to take the opportunity to thank the members of the assessment committee, both here present and online, for their efforts and work in evaluating your thesis and in providing opposition here today. I also want to extend our congratulations to your wife, future wife, your parents and sister, and everyone else here today, including perhaps your dog Sasha, who we missed being here, who have taken the time to watch the live stream and virtually celebrate this joyful event with you here today.
Thank you very much.
Thank you, Professor Groot, for a very nice laudation. Dear Dr. Leao, also on behalf of the Maastricht University, I congratulate you with the degree you have acquired. I've seen a very interesting defense and a nice thesis, and congratulations with that. I hope you can celebrate it together with your parnymphs, of course. I'm congratulations for you too. One of them is your wife, I think, I heard. Okay. Congratulations, of course, for Professor Groot, Professor Pavlova, Dr. Van Vechel, and of course your family and friends and colleagues on site and online. I would like to thank the members of the opposition for their work, and of course the PEDEL and the technical support team, because they made this hybrid ceremony possible. I'm about to close this meeting now, this ceremony. What we're going to do, we're going to make a picture here with Professor van den Heuvel on the background. You can already go to the reception room, which is outside, But please we have a photographer here and your parents and parents, of course, family, because we are going to make another picture at the foot of the stairs, and we can include the family in the picture, okay? And then afterwards we go to the garden where you can congratulate the young doctor. Having said that, I close this ceremony. Yeah, we need a photograph.